Everyone, I am so happy to be here with you all. I'm new to the Zoom. I've been participating in Zoom all year, but running them is new for me. So looking at the chat, I see people from all over, really cool. I think the closest one I see to me is Charlotte, but I did see Detroit, which is my home. So shout out Detroit. I am gonna cover kind of the ins and outs of family medicine today, what we do, what we don't do, when we refer, and then also I'm gonna cover a lot of the aspects of medical school and residency that you all may not be aware of yet. Some things I didn't learn until getting to medical school. So I just kind of wanted to open your eyes to some things. So when you do get to that point in your lives, it's not a shock. So I will go ahead and share my screen, start my presentation. I do feel like a huge part of shadowing in person that you guys unfortunately have been missing out on because of COVID is asking questions. Everyone has a different approach and different questions and why they're interested in things. And so asking questions is a huge part of shadowing. So my presentation won't take more than half of the allotted time. So I do really want to utilize that second half of our session to field any questions that you guys do have, because I do feel like that's pretty paramount to shadowing. So we'll go ahead and get started. All right. Okay, so family medicine overview. Again, my name's Erin Healy. I am an MD. There are multiple routes to becoming a physician, one of which is the MD route and the other which is the DO route. So Doctor of Osteopathic Medicine or medical doctor. You can find me on Instagram at @ErinMarie_MD, and let's get started. Okay, so timeline to family medicine: 4 years of undergrad, 4 years of medical school, and then 3 years of residency. That 3 years is specific to any primary care field that you go into: pediatrics, internal medicine, family medicine, but residency can take up to 7 years depending on your specialty. The surgical specialties are going to be a little bit longer. Ortho can be 5 to 6 years, general surgery 5 to 6 years, neurosurgery 7 years, and then tacking on different fellowships after that. But for myself, family medicine is 3 years, and I am electing to not do a fellowship and go right into practice. So I did my undergraduate training at Wittenberg University in Springfield, Ohio, and then 4 years of medical school in Royal Oak, Michigan at Oakland University, William Beaumont, and now I'm in Greenville, North Carolina at East Carolina University, finishing up my training. Very, very common to have breaks between that 4 and 4 and the 4 and 3 for any number of reasons. More common between the a lot of people get their master's, get different life experiences under their belt prior to going into medical school. I did not do that, but it's so common. I'd say majority of people in my medical school class did have some gap between undergrad and medical school. So there can also be a gap between medical school and residency. That can also be for a number of different reasons, most commonly if you don't land a residency position, which is not common, but it does happen, but you just apply the next year. So moving forward, testing timeline. So if you guys are all pre-med and interested in medicine, I'm sure you're aware of the MCAT. That's a doozy of an exam. I took mine my junior year of undergrad, and then that is the first of many testing hurdles you will encounter over the course of your medical training. I will now make everything specific about family medicine. So you'll take your step 1 during your second year of medical school, the second semester of your M2 year. And this is known as the big test. This is the score that's going to go on your residency applications, and a score that a lot of people put a lot of weight on. They're working to change that so it's not so heavy on your application, but it is notoriously the big test. Step 2 is taken your last year of medical school. Step 3 is during one of your first 2 years of residency. And step 1 and step 2, I believe, are 8 or 9 hours. Step 3 is a 2-day test. Each of those days are 8 hours. And then for family medicine, at the end of residency, you take your board exam. The board exam is offered multiple days in April and multiple days in November. Most people take it before graduating. So you take it in April, graduate in June. Some people wait and they'll take it in November after graduation. I actually just took mine last week, got great news 2 days ago, and I'm happy to have that behind me. Most jobs, and it's very state dependent, but most jobs will require you to be board eligible, meaning you've checked every box that means you're eligible to sit for the exam. to apply for that job. I would say all the jobs that I looked at requested that you were board certified, meaning you had taken and passed your test, but a lot of jobs are just, you just need to be at the point where you're eligible to take your exam. So the match, I have heard people describe it as the Hunger Games. I think that's a little bit intense. I would prefer to describe it kind of like a blend between sorority recruitment and the Sorting Hat from Harry Potter. I've actually seen one Harry Potter movie out of all of them, but I do know what the Sorting Hat is. It happens during your 4th year of medical school. You decide your 2nd or 3rd year what field you want to go into. So it's a family medicine talk, so we'll do family medicine. You decide you want to apply family medicine. 4th year comes around, you sit down, you get on the computer, and you look at all of the family medicine programs and decide which you want to apply to. There are hundreds in this country. And then you curate your application and you fire off your application. The average that people apply to is between like 40 to 60, but some people will apply to over 100 just to increase their chances of getting interviews. The kicker is with every application you send, you have to pay for that. So if you only apply to 10 places, relatively affordable, I think it's like 17 bucks an application, but if you're applying to over 100, that can really add up. And then you sit and wait, and you will get yeses, you'll get nos, and some people just won't even answer. Some programs won't even bother responding, and we've been told not to take that personally. And so of the yeses, of the interview invites that you do get, you travel to, and you either fly, you drive, you get a hotel, and that's all out of your own pocket as well. So kind of the point I was trying to make here is it can get pretty pricey. This was shocking to a lot of my medical school classmates and myself because the number, it can add up. Now, one of the benefits of the pandemic is that the 4th year medical students didn't have to travel. It was all done virtually. So they all saved a lot of money. And then after you go through all of your interviews, we'll say for a round number, you interviewed at 15 places. Okay, so you're going to submit your rank list from 1 to 15. And that is your list of preference, my number 1 program all the way down to my number 15 program. Well, every program in the country also submits a list of everybody they interviewed. Now that list can be 1 through 200, depending on how many that they interviewed. And then a computer software system will do this really fancy algorithm that I will never understand. And at their best program based on your rank list and the program's rank list. And then mid-March, everybody gets an envelope. Every medical student in the country gets an envelope on the same day, and you all open it at the same time. And you open it and you find out where you will be going the next year. And that is a bound contract. So when you open your envelope, where it says, that is where your contract is. So it's pretty binding. It's pretty big deal, pretty official. This was a photo from my own match day, and I included it because as binding and as serious and as permanent as that envelope may seem, 3 people of these 6 people in this picture are not currently at the programs that they matched into. And while that's not common and the rate of that happening is definitely not 50%, it does happen, it is possible. So I just wanted to iterate early in your all's budding medical careers that you are never stuck. If you're somewhere that you don't feel comfortable, you are never stuck, and there always is an opportunity for change. Dr. Eaton in the pink tie is in the Navy, and he matched into internal medicine at a naval hospital. And his career led him into flight medicine. And last I spoke to him, he is going to pursue an alternative route to internal medicine after doing flight surgery because he enjoyed it so much. Dr. Wegman in the blue tie did 2 years of interventional radiology and decided that really wasn't for him. And he is now training in anesthesia. And then myself, I actually matched into a specialty because, from a very young age, you're told you must specialize. That's how you make the most money, yada, yada, yada. And I was doing physical medicine and rehabilitation, which is a wonderful field. but I just felt like something was missing. I wasn't getting to have the broad scope that I had hoped for in medicine. Physical medicine is pretty specific to just that, physical medicine, dealing with patients with their injuries and recovery. And I just felt like there was something missing. So I was able to transfer and found a spot in family medicine and could not be happier. I also want to say that one of the other people in this picture matched kind of mid rank list. So, everyone gets bummed if they don't match their number one spot, but I still talk to all these people very regularly. The opportunities she has obtained from where she matched, she would not have been able to have those opportunities had she matched at her number one program. So she is, over the moon at where she's training, couldn't have worked out better. She couldn't be happier. So again, planting a seed early for you all that where you match does not define you. And there's also opportunity for change if needed. All right. So residency training. In family medicine, you are doing everything. You do just that. You're delivering babies all the way up to geriatric, palliative, end of life care. And so during residency training, this 3-year program, every month you're doing something new and you're doing something different. Now that could be the ICU with the critically ill patients. It could be delivering babies on labor and delivery, could be in the pediatric emergency department, could be general surgery, sports medicine, NICU, newborn, ear, nose, and throat, sports medicine, a whole range of things that you train in family medicine to really become proficient as a general practitioner. In no other field are you going to find the breadth of knowledge that you do in family medicine. Internal medicine is wonderful, but they don't take care of pregnant women and they don't take care of anyone under the age of 18. So they're also primary care, but they're missing that pregnant aspect, the newborn, the kid aspect as well. In the bottom right corner of the screen, you'll also see that there is an opportunity for electives. My program specifically was phenomenal with allowing for elective time, and that lets you hone in on specific interests that you have. So for me, I love procedures, I love weight loss medicine, I love lifestyle medicine. So I was able to kind of procure my own training by picking different electives. So I did a couple extra months in the skills clinic and the procedures clinic to really get pretty proficient at different procedures that I plan to do in practice, working with the weight loss specialty as well, so I can continue to strengthen my skills with counseling patients for weight loss. And I know a lot of my other friends, if they're interested in going into a sports medicine fellowship, they'll tack on some more orthopedics or sports medicine into their training. And so families are great because while you have exposure to everything, you don't have to focus on everything. You can really narrow down to what you want to do as a physician moving forward. And here's a list of a lot of the opportunities that you can have for fellowship after family medicine. Most of these fellowships are just a year or two. And so while it does lengthen your training overall, you can really focus on what you want to focus on. Again, fellowships are not necessary or mandatory. I myself am not doing a fellowship. I did have interest in sports medicine at one point, but realized that through my training, I do feel strong enough to practice sports medicine generally in my day-to-day clinic. So I'll be seeing everything and not working at a sports medicine clinic, but I do have the skills I need to manage sports medicine aspects in clinic. And like I said, you don't have to do it all in residency. You get trained in everything, but that does not mean you have to carry it with you. I really enjoyed labor and delivery and delivering babies and taking care of pregnant women during residency, but I do not want to carry that skill with me into my future career. So I will not be practicing labor and delivery next year. So here is what a day in the clinic may look like for me. You get there a little bit before 8 o'clock because that's typically when the first patient will get there, and you're there till about 5 p.m. because inevitably you'll be running a few minutes late. Even if your last patient's scheduled at 4:10, you never know what's going to walk through the door, and we'll cover some of those things moving forward. Now, I won't read all of these for you off the screen. I just provided this example for the variation that you can see from a day to day. When you have your schedule in place, there'll be blocks for different areas. And I'd say 60% of those are going to be some type of follow-up care, chronic disease management, your diabetic patients, your patients with high blood pressure, your patients with arthritis or other rheumatologic disease. But then you'll also have a good chunk available for acute issues. Someone who's coming in with an earache for 2 days, or last night during their soccer game, they hurt their ankle. It's still hurting this morning, so they're coming on in. Kind of those same day emergencies. We also see patients when they get out of the hospital, and those can either be a very quick visit, you know, if they're admitted for something simple like a skin infection, there's not much to follow up on. But sometimes you have patients that are admitted to the hospital for 3-4 weeks, and they have this huge list of things that were covered while they're in the hospital. And then when they get out of the hospital, they come to see you just to make sure everything gets lined up. Sometimes medications are changed in the hospital. And so you just need to make sure that moving forward, you're on the same page with the doctor that took care of them in the hospital. All right, so moving forward with what we see in clinic. So here's a patient. Again, none of these are patients that I have seen. I obtained these images all off the internet because I would not want to violate HIPAA or show you anything that was a real case that I had seen, but I can assure you that I have seen similar cases in clinic. So this patient came in with a cough. It had just been a couple days. She was 68 years old, you know, history of, let's say, hypertension, diabetes. Other than that, though, pretty okay. Her diabetes is well controlled. She's not too sick, but she's had this cough going on for about a week, we'll say. And she just wanted to get checked out. She asked, you know, maybe I need an inhaler, or can you look in my throat? Maybe I have a sore throat. Maybe this is strep. And while a lot of the time you can just, if the clinical symptoms are showing it's an upper respiratory infection, by all means treat it as such. But when I listened to this patient's lungs, something sounded off. And so you can see in this picture on the lower, looking at the screen, it's going to be the lower left side, but that's actually the right lung. You can see that consolidation. And so that made me think pneumonia. This was a community acquired pneumonia case. And so that goes to show just how important it is to have strong clinical skills. You know, we order labs all the time and we can read lab results, but if you're not doing a great physical exam while you're in the room, you might miss something. So if she came in and said, oh, it's all up in my throat, it's all up in my head, but I hadn't taken the time to listen to her lungs, we'd be missing a pneumonia. And what's important about community acquired pneumonia is young and healthy person, they're going to be getting a different antibiotic than if it's someone who maybe choked and swallowed a little bit of their food. That would be a different antibiotic. Also, we use the CURB 65. So when you get into your medical training, you'll realize there are acronyms for darn near everything. CURB 65 is for pneumonia. Are they confused? How fast are they breathing, which is their respiratory rate? How high is their blood pressure, or more seriously, how low is their blood pressure? And what's their age? Is it over 65? And if you check a certain number of these boxes, it encourages you to actually admit the patient to the hospital. And sometimes not only admit them to the hospital, but get them in that ICU level care. So family medicine kind of does it all. This patient comes in to see you for a cough and could end up in the intensive care unit. So that goes to show you just how important your medical training is, and looking for a lot of these moving parts that could easily be missed. Next up, someone's coming in with palpitations. So their heart feels like it's beating out of their chest. Well, did they just go for a run beforehand? You know, you got to ask all these questions, ask them their history. Anybody in the family have any history of any heart issues? Do they have any history of any heart issues? Do they have a history of panic attacks? I can't tell you how many times someone comes in because they feel like their heart is beating out of their chest, and it is attributed to anxiety. Now, while anxiety is very common, someone can have anxiety, they could also have a life-threatening cardiac issue going on at the same time. So here we are again with recognizing the importance of good quality clinical care in the outpatient setting. And so whenever anyone comes in and they're feeling lightheaded or they're having chest pain, chest pressure, heart beating out of their chest, weird pulse, that's always a cue for me to get an EKG. So we get the EKG, and I do not expect anyone to be able to read this rhythm, but this is what is referred to as an irregularly irregular heartbeat. And it turns out this patient had atrial fibrillation. So on the right side of the screen here, I'm showing you what a normal rhythm looks like. At the bottom, you can see atrial fibrillation, which is an irregular beating of the heart. This is dangerous because someone can flip in and out of atrial fibrillation. Their heart rate can go all the way up to the 180s when they're having atrial fibrillation, but not maintaining at the 180s. It'll go 100, 180, 160, 180, 140, 170, and kind of be all over the place. And when they're in AFib, that's not the dangerous part. It's when the heart turns back into normal sinus rhythm that they have a risk for throwing a clot, which could cause a stroke and or worse, lead to their death. So even if someone's coming in and just saying, oh, I just feel like my heart is fluttering, you have to recognize that there could be something much more dangerous going on. And this is something that we see in our clinic I shouldn't say quite regularly, but it's not infrequent for a patient to have AFib. A lot of different things can cause atrial fibrillation. Like to correlate with the last case, pneumonia. So having pneumonia can throw someone into AFib, but also other things such as chronic alcohol use, acute alcohol use. So, going on like a weekend bender can also throw someone into AFib as well. So again, underlining the importance of thorough physical exams, which can be difficult when your patient slot is only 15 minutes. So next time you go to the doctor and they're running a couple minutes behind, know that there could be other stuff going on as well with the patients that were seen before you. All right, so this was a patient that I also saw, not this picture again, this was gotten from the internet. She stubbed her toe on her nightstand and it was hurting her. And she came in to see me. She was tender to touch, so we got an x-ray. And there are a set of criteria called the Ottawa ankle rules. They have the Ottawa foot rules. So shout out to Canada for coming up with the Ottawa rules. But the big one is, can they take 4 steps? Can they take 4 steps at the time of injury, or can they take 4 steps in your office? In this patient, the answer to that was no. So we got an x-ray, and as you can see, there is a fracture of the 5th metatarsal. And I don't know if you guys can see my arrow or not, but with a 5th metatarsal fracture, it can be a little difficult to manage because you have to recognize that if there's a fracture, but the bones are still lined up pretty well, you don't have to necessarily do anything too crazy. Immobilize the foot, and as soon as they're able, do range of motion exercises, and as soon as they're able, they can bear weight. If there is a little bit of displacement, so less than 3 millimeters of displacement, you immobilize a little bit longer and keep them from moving the foot, and it still should heal pretty nicely. However, if there are more than 3 millimeters of displacement, this patient is an orthopedic emergency and needs to go have surgery done. So stubbing your toe on your nightstand could mean lay off of walking, and as soon as you're able to, you can go ahead and put weight on it again. Or if you have some displacement, it can mean you're having surgery. So again, recognizing the importance of just knowing your skills. And as you can see, we've done 3 very different cases. We had an ortho case, we had a cardiac case, and we had a home case, all coming into our clinic on the same day. So just showing the breadth of knowledge that family medicine has. It's a pretty cool field. You can go as narrow focus as you want to, or you can stay broad. A lot of my teaching faculty that I work under in residency are still delivering babies and then also working inpatient, so in the hospital, taking care of patients that are admitted to our service in the hospital, and then also later in the day going over to the clinic and seeing regular patients coming in to see them for all of the things that we just talked about. Another good part of being a good doctor is knowing when to refer to somebody else. So while we are great at a lot of different things, there are experts that are even better at all of those things. So if something gets to the point where it's out of our scope, or we have a question, or if this is, could be life-threatening, that is when you should refer. Obviously, I'm not taking out somebody's gallbladder. Obviously, I am not putting that pin in our patient's foot who stubbed her toe. But having a good team of supporting specialists is huge in family medicine. So while we can and we do diagnose and treat so many different things, having your specialist in your back pocket is critical. So procedures. I mentioned earlier, I love procedures. I love getting my hands dirty. And that'll be something that I'm practicing next year when I go out on my own after residency. And so here is a number, very small number of procedures that a family medicine physician can do. Again, this just barely even scratches the surface. So like I said, we deliver babies, and those babies come and become our patients. So we're performing the circumcisions on male infants. We're doing skin biopsies. If someone has a funky looking mole, if someone has an abscess on their leg or an infection, we can drain the infection and give them the right antibiotics. We can do colposcopies. Colposcopy is taking a sample of a woman's cervix if she's had an abnormal pap smear. We do endometrial biopsies, which is taking a sample of the endometrium, which is the lining of the uterus, if there's concern for a woman having some kind of growth or malignancy or something like that. We also do implantations and removals of long-acting birth control, so Nexplanon or IUDs. I love a good joint injection. It does provide a lot of relief for patients with arthritis, so knees, shoulders, hips. One of my attendings actually even does vasectomies in the clinic. That's not something I'll be doing next year. I just don't have a specific interest in it, but it is possible. And then of course, obviously we do routine pap smears on women as well. So diving a bit further in these procedures, this is a Nexplanon. It is about the size of a matchstick, and it gets placed into a woman's arm and acts as birth control. So a lot of people, when they hear birth control, they think of the pill. There are many other forms of birth control besides the pill, and Nexplanon is just one of them. The hormones are actually in that stick, gets implanted. Once it's in the arm, you can't see it. The woman can feel it, but you can't see it. You wouldn't even know it's there if you weren't checking for it. And then years later, you have it removed. And we do both of those things in our clinic. The IUD is a similar type of birth control to the Nexplanon. However, it gets implanted in the uterus. My labels got kind of cut off there, but you have the vaginal canal at the bottom, which then changes into the cervix, and then up above is the uterus, and you implant that T-looking shape into the uterus. The strings hang out just a little bit to remove it, but that is something that we do in clinic. We take them out, we implant them all the time, kind of bread and butter for us. Colposcopy. This is not something that is routinely done by all family medicine doctors, but where I'm practicing is quite rural. And so a lot of the family medicine doctors are doing a lot of everything. And like I said, the colposcopy is the next step when a woman has had an abnormal pap smear. And a pap smear is performed every few years. The guidelines actually have changed. So for those of you who have never had a pap smear before and aren't familiar, starting at age 21, a woman has a pap smear performed that looks for precancerous cells. And that is done every 3 years until you turn 30, then it's done every 5 years. Well, if you do have cells that come back a little peculiar, doesn't necessarily mean they're precancerous, but oftentimes we'll go take a sample. And so the colposcopy, you use this microscope and you get a larger view of the cervix. You put a solution over the cervix, and the solution will change color of any cells that are atypical. And then a biopsy, or a little pinch of the tissue of the cervix, will be taken and sent to the lab, and a pathologist will look at it closer and let you know how concerned you need to be. Sometimes the concern level is not at all, and sometimes it's precancerous or even a cancer that we find. So again, not every family medicine doctor does this. I'd say only about 10% of family medicine doctors do colposcopies, but I'm pretty lucky to be at a training program where I'm getting exposed to a lot of procedures. So an incision and drainage of a skin abscess. This is something we see all the time. A lot of people actually go to the emergency department for this, but it's definitely something we can manage in clinic. I will say, if you ever experience one of these, wear a face shield. Yeah, wear your face protection, because I've seen these hit the wall and you don't want to be between that. And they don't smell great either, but it provides immediate relief for the patient, which is awesome. They feel so much better. So what you do is you prep the area, you sterilize it. I did try to embed some videos, but I didn't want to just sit here and have you guys watching. Dr. Pimple Popper, I'm sure, has one of these on her page, but you prep the area, you clean it with a betadine or chloroprep, which is an antiseptic solution. And then you numb the area using lidocaine. That's the worst part of the procedure. It feels like a little bee sting, pinch and burn. You inject the lidocaine into the area, wait a few seconds. It numbs the area really nicely. You take a scalpel and you make a small incision, and then you cross your fingers and pray that there is not enough pressure behind it, that it's going to squirt up and get on your scrubs, or if you're in clinic, on your dress clothes. But the patient immediately feels better. And then you vacuum out everything, not like with a literal vacuum, but using cotton swabs and just like pressure with your hands, kind of just get all of the purulent matter out. And you typically will have the patient come back in about 2 to 3 days just to make sure everything's healing appropriately. You give them return precautions. You know, if you have severe pain, if you get a fever, if you're starting to feel chills, if the pain is keeping you up at night, definitely give us a call. Typically that doesn't happen, but it is important to kind of cover all your bases when you're performing a procedure. All right, so I kind of already talked about my path a little bit, but I am going to focus on outpatient family medicine. I am currently in Greenville, North Carolina, but my husband is a military physician based in Norfolk, Virginia, so about 2 hours north of here. So in a few months, I will be joining him up there, where I'll be practicing outpatient medicine with a special focus on weight loss and lifestyle medicine, procedure heavy. With his military history, we will be moving quite frequently. Every 2 to 4 years, we'll get a reassignment. Our next reassignment is June of 23. So I will be practicing in Norfolk until June of 23, and then we will see where the military sends us from there. But I will be eagerly anticipating finding another practice for wherever we do end up. So that's just a little bit about where I am heading after residency. And if you all have any questions, I'll be happy to answer them. You can find me again on Instagram, ErinMarie_MD. Feel free to shoot me DMs with any questions, anything I can help you guys with moving forward. I was a skeptic when it came to family medicine when I was in my medical training. Actually, I come from a long line of family medicine physicians, so I think I was trying to be a rebel, like I'm going to do anything but family medicine, but look at me now. I am loving the field that I am in. Also, feel free to take down my email address if you have any questions for me at erinmariemd@gmail.com, and I am happy to start answering questions.
Thank you so much, Dr. Healy. This was absolutely awesome. Everyone in the chat loved it. Thank you for explaining everything to us so succinctly and precisely. It was awesome. There were a ton of questions, so we can start going through some of those.
Great.
So towards the beginning, when you were talking about the match, a lot of people are saying it sounds really stressful, and we can only imagine how stressful it must be. And so what happens if you don't match? And can you kind of like talk us through that process?
Yes. So if you don't match, there is a process called the SOAP, the Supplemental Offer and Acceptance Program. So by entering the match, if you don't match, you can enter the SOAP. You find out if you matched on a Friday, or you find out where you matched on a Friday. That Monday, you find out if you matched. So that Monday, everyone gets an email, and all the email says is, you did it, or let's find a plan B. And part of that plan B is the SOAP. So the SOAP happens over Monday, Tuesday, Wednesday, Thursday, I believe. So there's 4 more rounds. of the applying process. So you can scramble into a spot. It might not be in the field that you wanted to. If you're trying to do something very competitive like dermatology, you're not going to scramble into a dermatology position. Those all fill very readily. But fields like primary care fields like peds and family medicine and internal medicine don't typically always fill. And so you can scramble into one of those spots. If that doesn't work out for you, there is always, I don't say like it's always next year, but it's true. There is always the following match. Just because you didn't match the first year doesn't mean you can't apply the next year. So every med school has an advisor, and part of their training is to help people find what to do for if that were to happen. I will say in my graduating class of 100 in medical school, only one person didn't match, and he ended up scrambling into a spot. I will say I shouldn't say this, he didn't match but this person was very arrogant with their rank list, and they only ranked 3 really high rated programs in a very competitive field. He did like 15 interviews, but only ranked 3 spots. So kind of shot himself in the foot, but it happens.
Great. Thank you so much for explaining that process to us. Also kind of on the topic of residencies, there were a couple people wondering, and it's kind of a subjective answer, but like how competitive are family medicine residencies? Like your take on that?
Sure. So family medicine gets a bad rep sometimes, whereas people will be like, oh, there's always open spots. It's not very competitive. But, if you're going to a big city like Los Angeles, New York City, Chicago, Miami, Detroit, those positions they're hard to fill. Like if you're wanting to be in that city, it's hard to fill. If you're up for going anywhere and like you're down to be in North Dakota, if need be, like you shouldn't have any trouble matching into family medicine. But the reason that family medicine is, I shouldn't say attainable or accessible, but because there are more training spots. There are more training programs for family medicine because there's such a demand and a need for primary care. With the way insurance has changed, most people need to see their primary care doctor before they can go see an orthopedic surgeon, before they can go see a dermatologist. So there needs to be more family medicine doctors. And in a world where, money seems to be king, people are trying to go into specialties to make more money. And so that also takes away from the family medicine pool, if that makes sense.
Yes, thank you so much for clarifying that. A little bit more to the residency questions because there's a ton of them. But a lot of people just wanted to understand the difference between internal medicine and family medicine and how those residencies look different.
Sure. So internal medicine and family medicine are both 3 years. A lot of people will go into internal medicine with the intent of specializing or going into fellowship. The fellowships off of internal medicine length. So your residency is not 3 years, it's essentially 6 years. And those are your GI doctors, so your gastroenterology. Those are your rheumatology doctors, your cardiologists, your, I'm probably going to forget some, but pulmonologists. So if you're going to specialize, you go into internal medicine. Now, I just showed you all these opportunities that family medicine has as well, but those specialties are just going to be a year or two. And you're not specializing per se, you're just doing a fellowship to kind of add another layer of foundation to your training. So also with internal medicine, you do a lot more in hospital training. So you're taking care of a lot of patients that are admitted to the hospital, whereas family medicine has a lot of outpatient work. Also, like I touched on, internal medicine, if you're over or under the age of 18, they're not interested. Even if that patient is inside of you as a pregnant woman, they're not interested, they're not taking care of that. So family medicine, we take care of pregnant women, newborns, all of the kiddos, all the way up to 18. And then even when they become adults, we continue with them. So that's another difference.
Perfect. Thank you so much for clarifying that. I know a lot of people get confused. Lana and I just learned through social distance shadowers, so we understand that confusion. There are also a lot of people asking about what helped you make your choice in schools. Like what factors do you have to consider? You've mentioned family life a little bit.
Sure. Yeah. So with medical school, I spent my childhood in Ohio. I went to undergrad in Ohio. My parents were in Ohio, but my mom grew up in Detroit. I had a whole bunch of family in Detroit, and I was just ready to get out of Ohio and try something new. So I applied to a lot of the Midwest schools to stay near family. Obviously very glad I landed in Detroit. That's how I met my husband. So that worked out nicely for many different reasons. But now we're living in the South because he's in the military. But he was born and raised in Detroit. Detroit will always be home. So from a medical school standpoint, I knew I wanted to be around family. So that was my driving force. For residency, I'm kind of in a unique situation because I'm playing the military game as well. So my husband's training in Norfolk. This was the closest training position that I could transfer to Norfolk. So a little bit unique there, but you have to think about what's important to you. If you have a significant other, are you going to have to be away from them? Are their job going to be able to transplant with you? Are you someone who thrives being around family? Are you someone who needs something to do? I'm the type of person, like, I don't need to do something when I have time off. I'm cool with breathing and going for a walk and going to the gym and sitting on my couch, but some people need that big city life. So that's also something to keep in mind.
Awesome. Thank you for telling us about that. A lot of people were interested in kind of like factors to consider. There was a specific question about like the emergency medicine fellowship, I think.
Mm-hmm.
So if you train as a family medicine resident and then do that fellowship, what differentiates that kind of physician from like a physician who did the emergency medicine fellowship?
Sure. And my husband, who is an emergency medicine physician, he and I chat about this all the time. I think emergency medicine is so cool. I have no interest in running a level 1 trauma. That is somebody that's coming in just like you see on Grey's Anatomy with like the fence post like through the neck. I have no interest in managing that. My husband gets really excited about that. So with emergency departments, there are different tiers of trauma levels. So level 1 trauma, level 2 trauma, level 3 trauma. Can't tell you the difference off the top of my head of what they are, but I do know that a lot of family med doctors that go on to do the emergency medicine fellowship, it's only an extra year. They are very comfortable running a level 2, level 3, level 4 trauma center, no problem. And they can, and they're able to run level 1 trauma if they have that interest. But if that helps at all, you're training to be able to focus on emergency medicine. So in my residency training, I have done 5 months of emergency medicine training. So let's see, that's almost a sixth of my residency training has been in the ED. So we do get a high volume and we do kind of cover a lot of that stuff. Primarily because we see a lot of these emergencies in our clinic. A lot of people walk into the clinic and they're like, hey, I think I need some antibiotics for my foot. This has happened to me last week. And I said, sir, you need to have your foot amputated. And I had to send him immediately to the hospital, and he had his foot cut off in less than 3 hours. So we do see these emergent things in this exposure.
Great. Thank you for answering that question for us. I think it was a little murky, so thanks for clarifying that. There was another question. You were talking about like military life. So when you are applying for jobs and you kind of tell them like, I'll only be here for the next 2 to 4 years, how does that look like? Like, do jobs look down upon that? And how can you ensure that you can find a job like everywhere that you'll be going?
Yeah, so kind of being a family medicine doctor in itself is job security, just because there is such a need for primary care. And not that it's about money, it's about, helping people, but at some point you do have to be able to pay for the house that you live in. And when I was applying for jobs, I was very surprised at how high paying a lot of these family medicine positions are, just because there is such a need for it. And being in this military situation, I myself am not in the military, but my spouse is. So wherever we're going to be living is going to be a military town. So kind of everyone in those areas does recognize like, this is just the way of life around here. And so when I was applying for jobs, the first thing I said to them was, hey, I have from this date until June of 2023 to offer you. If you're comfortable with that, let's proceed with this interview. If you're not, like, thank you for your time. But it's just something you have to be upfront with. And everyone, I only applied to 3 places and all 3 were like, yeah, we get it. It happens in this city all the time.
That's awesome to hear. I know a lot of people are interested, so thank you for explaining that.
Oh, and on that note, if you join the military, and this is obviously not a plug because I did not do this, but if you join the military, they pay for your medical school training 100%, and you have no loans, and then you owe them back the number of years that they provided payment for you. So my husband, and residency training does not count. It counts toward retirement for the military, but doesn't count toward your payback. So my husband owes 8 years after medical school to the military. But military residents get paid almost twice as much as civilian residents, and then he'll owe back 4 years. So if you have any questions about that and that process, I'm pretty well versed for not being in it myself. So if you have any questions about that, please DM me, email me. I'll be happy to help.
Great, thank you. I know a lot of people always ask about that, so I'm sure you'll get some DMs soon. Okay, so when you're going through the procedures that you could possibly do, a lot of people are interested seeing ear piercings on that list. Is that like cosmetic, or like is there a reason? A lot of people are interested to hear more about that.
Purely cosmetic, and like chalk that up to like, I didn't touch on this, but like I plan in the, obviously I love taking care of my diabetic patients and my hypertensive patients, but after graduation, I will be Botox certified, and that will also be something I offer in my clinic. If like a woman doesn't like some wrinkles on her forehead, like purely cosmetic, not covered by insurance, but ear piercing, Botox, and you can get certified in fillers on that stuff too, but strictly cosmetic.
Awesome, thank you for clarifying that. That's so interesting. We never heard that one before. So there are tons of questions asking about if research plays any part or like a major role in family medicine residencies. Is that something that is focused on as much?
In like regards to getting into family medicine residency?
Yeah.
So yes and no. I think that any residency likes to see that you had an interest in research. I'm personally not interested in research, but I did some in undergrad. It wasn't anything, super extravagant. Well, I guess kind of. I spent a summer at the University of Tennessee, Knoxville, doing research there. But it also depends on the program that you're looking at. Like where I am here, it's very community driven. Like they just want to take care of the patients, and it's not something that's super heavy on research. But if you're going to some of these bigger institutions like Ohio State or Michigan or something like that, they're going to want to see that you did research. So it's very dependent on where you're going. Something on your resume is fine. Something that you can expand upon. It doesn't have to be, you didn't have to like cure cancer or anything crazy like that. Unless you're really like shooting for the moon with what school you want to go to, then you might want to do something a little more substantial. But overall, not mandatory.
Awesome. And then kind of going off of like applications, a lot of people are wondering what you specifically did and what you recommend for like medical school applications, and I guess like more relevant for you, like residency applications.
Sure. And keep a running CV. So anytime you do anything at all, CV, then when it comes time to send out your application places, you have it all in one spot. Even if you just do one thing one time, put it on there. And then when it comes time to send them out, look at your CV and recognize like, oh, is this one kind of just fluff and really doesn't matter? Then you can take it off. And then you can narrow down to what is important, what you enjoyed, what you stood out, what stands out on your application, and kind of build it from there. So for example, when I was in medical school, I was asked by the Detroit Tigers to come give a talk at Comerica on general sports medicine. That one was pretty cool. I only did it one time. Like I didn't do it regularly. It took me 20 minutes to give the talk. But I put it on my CV and I moved on with my life. And then, a couple weeks later, my children's hospital, they do what's called like moonbeams for sweet dreams outside of the pediatric hospital, where like hundreds of volunteers get together with flashlights. And as soon as the sun goes down, everyone waves flashlights. And then the kids in the hospital beds from up above are waving them back at us. So I put that on my CV. And when it came time to send it out places, I realized like waving a flashlight was like really sweet and really like cool to do, but it might not hold a lot of weight on an application. But I was happy that I had it on there, if that makes sense, to like look back on. I eventually took it off for the one I sent, but it's still on my like draft.
Great, thank you for that advice. There was a question that just came in asking if you've met any family physicians that had a strong public health background, and if someone does have like an MPH or something, what capacity can they use that in as a family medicine physician?
So I know of at least 3 of my faculty members that have public health history, like they have their degrees in that as well, and they use that for like patient outreach. You can keep it involved with different research projects that are going on. Hard for me to talk a lot on just because I don't have that personal history, but I know where I am is very rural, and there's a lot of opportunity for public health. And so just giving lectures, giving grand rounds, you'll sit through a lot of lectures in residency. Med school is very heavy lecture. Residency stays pretty lecture heavy as well. My whole afternoon today from noon to 4:30 p.m. was sitting in lectures and learning. So opportunities for education are there for MPH people.
Great, thank you for sharing that. There was a question asking if you had any tips for non-traditional pre-med students. I know you mentioned like it's normal to have gaps. So do you have any advice for that?
Figuring out your why. You know, why did you take those years off? And honestly, like a good majority of it is like to build my GPA. I needed to take that time off, and that's appropriate and that's totally fine. You may want to dress that up a little bit when you're doing your application. When I applied, I did not think I was going to get into medical school the first time around, and I was very prepared to take time off. And I don't know, I must have like flipped a coin the right way, and it worked out for me to go straight through. But having a plan, knowing your why, maximizing those years off. You know, don't just do your post-bac classes and raise your GPA. Find something else to do in the meantime that can also kind of pad your application.
Great, thank you so much for that advice. This is a good question. Did you ever consider the PA route or even the DO route into medicine, or was it like always MD?
So my dad was in business. His whole family were turkey farmers. So there's no medicine on that side of the family. But on my mom's side of the family, both my aunts are family medicine doctors. I have 2 cousins that are family medicine doctors. One of my aunts is married to a physician. My grandfather was a physician. So very doctor heavy on my mom's side of the family. And I did not know what a PA was until after I started medical school. So no, I did not consider a PA because I did not know that it existed. I do feel like it's a really wonderful route for people to take. I know it's also very competitive to get into these days. But I did not consider it myself. I do sometimes think back and wonder if I would have considered PA. Hard to say. I do think I would have had thoughts like, because PAs have to work under a physician, you know, all the mid-levels in my clinic have to sign their notes out to our attendings, and the attendings have to co-sign all of their notes. So while PAs do have a lot of autonomy in a lot of regards, they still are working under someone. So I do always wonder, like, if I were a PA, would I have had that what if kind of thought? But hindsight's 2020, it's hard to tell. But good question. I do think it's a really wonderful field.
Great. And kind of going off of that, there were some questions asking how common it is to work with like PAs and NPs in family medicine and what they do. Is it like similar to what you do? Do they do different things?
So PAs can do pretty much everything that a resident can do. And that's kind of what we see in at least my residency program. Everything that a resident is doing, we have more nurse practitioners filling those roles, but it's a similar spectrum of care that they provide. So we have NPs that work in our inpatient units, so taking care of patients that are admitted to the hospital. And we also have NPs that work in our clinics, seeing patients on a day-to-day basis. We don't have any mid-level providers that do procedures. I don't know if that means they can't. So I don't really have a good answer for that. I just know that we don't have any that do that at my office.
Awesome. Thank you for your answer. I guess we can maybe do like one more question and then start wrapping up.
Sure.
So for the final question, there was people asking like where you can work later as a family medicine physician. So like private practice versus academic setting, and what the differences look like, and like why you would choose one over the other.
Sure. Really good question. I myself have no interest in running my own private practice, just because despite my dad being in business, I am not business inclined at all. And I just don't have an interest in that. I may someday work for a private practice. Like, I will show up and give you 100% as long as you give me my paycheck. That's all that I need to be involved in. Private practice is a business. It is a business. Even if you're not the one that runs it, someone is running that private practice business. And those are the offices that, like, they don't have drug reps coming in anymore. That kind of fizzled like 5-6 years ago. I don't know if you've seen the movie Love and Other Drugs. It's very cheesy. I think Ryan Gosling is in it, but that really just shows the pushing of the drug reps to a private practice. And they are about their bottom dollar. Obviously, they're about patient care and taking care of the patient and this and that. But at the end of the day, they are having to make money to keep their business afloat. For an academic setting, that is kind of overseen by the hospital, and the hospital is the business side of the practice. So you're not having to worry about the bottom line and the turnover and this and that. A difference that you'll see in private practice, you'll have a lot of private insurance patients, which seem to be from a higher societal economic background. A lot of the academic hospitals, you'll see a lot of patients that have Medicaid and Medicare and are financially burdened. So that's another difference there. Private practice tends to pay more. But again, when I was looking for jobs, I was very surprised at how high the salary was at any of the positions that I looked at.
Great, thank you for clarifying that. So we will wrap up with this last question we like to ask all of our guests. Do you have any last piece of advice you'd like to leave us with as undergrads and postbacks and master's students navigating through the pandemic?
Yes. So navigating through the pandemic, reach out to people, ask questions. Like I said early on, like the biggest piece I think you guys are missing is that the question asking piece. So I know there are a ton of physicians that are on Instagram and that are there and willing to help. I think if you go to my Instagram and go to who I follow, that'd be a good source for a lot of practicing physicians. Maybe don't tell them I sent you, because I don't want them to think that I'm like conning people off on them, but just ask questions. Even your own physician that you go and see, they're always willing to help. But an overall piece of advice that somebody told me when I started medical school that really I carried with me through medical school and residency, even to the point where I'm giving a lecture tomorrow to a group of like M4s that are graduating into residency, like health and wellness in residency and how to take care of yourself in residency. Cannot pour into someone else's cup if your own cup is empty. So you have to keep your own cup full so you can then pour into other people's cups. So take care of yourself. If you're drained out, if you're burnt out, if you're not in a great mental headspace, if you're not like physically where you want to be, you're not going to be very productive with helping other people. So it's super important as a medical provider to take care of yourself. Even if it sounds selfish, self-care is not selfish. It is self-care and important. So take care of yourselves.
Thank you so much, Dr. Healy. This was an amazing presentation. You really helped explain family medicine a lot to us and to some people who haven't been to our other talks. We all learned a lot. Thank you for that advice. We think self-care is super important, so we completely agree. Good luck on your journey and from where you'll go from here. We'll definitely stay in touch. We'll put Dr. Healy's Instagram in the chat one more time. You guys definitely give her a follow, ask any questions. And yeah, thank you so much for being here.
Thanks, guys. I'm always available. Thanks. I'm always available for questions. Now that I'm done with boards, I have significantly more free time. So I'm happy to help you guys. I love giving back to upcoming med students and pre-med. So by all means, ask away.
Thank you so much.
Thank you so much.
Have a great rest of your evening, and we'll